Sepsis is something that we can be proud of in emergency medicine. Research was not our forte when we started this business. We weren't known as the academically strongest department in our medical schools. You know, we had an impressive beginning. It's only been about, 30 years or something, but we weren't known as the powerhouses for research. And there was a lot of criticism of our specialty when it came to not incorporating the critical care people at the very beginning. And if you know what's going on in Europe, their emergency medicine has been slower to start up as a specialty, but they have incorporated the critical care people from the beginning. And so it's a bit of a different looking specialty where they're more emergency critical care specialists. One of the things that we should be proud of is our work in sepsis. It comes from people like Manny Rivers, who are hybrids that are both internal medicine and ICU boarded, as well as emergency physicians. It's fortunate they've decided to really make their home emergency medicine. If you ask Dr. Rivers if he's what kind of doctor he is, I think he'd probably say, I'm an emergency physician. So we do borrow from our critical care colleagues in some respect, our hybrids, but this is something that for years and years and years, there wasn't much progress. I mean, sepsis mortality didn't change for decade after decade after decade, and here we are in emergency medicine. 2001 is when our landmark study that Manny Rivers published in the New England Journal came out. It's now 2008. It's been 7 years, and we're making all kinds of progress, and mortalities have dropped significantly in the treatment of sepsis. And so, you know, that's something that we can really tout. It's another thing that we can tout is stuff like Nexus and C-spine rules. I mean, that kind of research is of a higher quality than most anything that you see in internal medicine and in ICU research. So anyway, with that sort of introduction, we're gonna start on the first abstract. Now, I think that you have to put a star and circle the first abstract. That's the kind of paper that you need to have in your office. You know, it's the kind of thing you might need to refer to. It's a landmark paper, and I want you to circle it. And just about the background of this, just to remind everyone and myself, is that we always used to look at septic shock and people that were getting into trouble with sepsis in terms of their vital signs. Their blood pressure is low, we have to do something. And what Manny Rivers and those that he worked with before him proposed that there's subtle things that are going on that we can't see that indicate that someone is going south, and that we need to direct our therapy towards those other more subtle markers. And what kind of things we're talking about are things like the venous saturation of oxygen. Normally when you have a venous, normally when your blood goes out to the tissues and comes back and it's pooled together, its saturation is about 75%, something like that, 80%. It might go down a little bit if you're exercising, you're utilizing more oxygen in your tissues. But when it starts going down to 60%, 50%, it means that the tissues are starving. And you really know that the tissues are starving because if you look at the hemoglobin molecule, once it carries 4 oxygens. And once one oxygen is taken off of the hemoglobin molecule, I don't know if I'm giving too much detail here, but I'm into it, so it's over. Once one oxygen is taken off the hemoglobin molecule, it changes its shape so that the second oxygen is very, very hard to take off. Once 2 oxygen molecules have been taken off the hemoglobin, it's almost like a covalent bond. And so when tissues are returning oxygen that's only 40% or 50% saturated, it means that they're starved to death. They are just trying so hard to pull off that oxygen. And that's the whole theory behind the goal-directed therapy, is that we can see these numbers of starving tissues even before the blood pressure drops and other markers start to tell us what's going on. Manny Rivers, and it's hard to believe that such a famous study, and most of us know, you can actually quote the figures, that there were only 263 adults in that whole study. And the patients were randomized into 2 groups. One group got standard therapy, where they had, actually, to be honest, things that we don't even do in a lot of our patients in our department. They got CVPs. Not all of our patients get CVPs. I don't know if you probably don't do CVPs on all your patients with sepsis. They got their blood pressure taken, they got urine output, antibiotics, and then they were shuttled off to the ICU for the regular routine care. In the goal-directed experimental group, they got a lot of things, and I'll just sort of refresh our memories about this. What happened is that they got their CVP measured, and until their CVP was in the 8 to 12 range, they were continued to give crystalloid. Then they had their mean arterial pressure addressed. And remember, the interesting thing about the goal-directed therapy is not only did they give them pressors for low blood pressures, but if they had highish blood pressures, a mean arterial pressure greater than 95, they gave nitro. When's the last time you thought about giving nitroglycerin to a patient with septic shock? And that's what they did. And then once they normalized the CVP and the mean arterial pressure, they then turned their attention to this saturation, this venous saturation, mixed venous saturation. And until it got to be 70 on these continuous monitors from the Edwards catheter that they had inserted in the central circulation, they would continue to give inotropic agents. In other words, they were resuscitating people that we normally wouldn't have resuscitated. We would have said, we're good, and they kept pushing with the dobutamine and blood transfusions until they got to that range. The results, when they came out, hit like a bombshell. The mortality of patients in the hospital in the standard group was around 47%. In the goal-directed therapy, it was 31%. I'm rounding the numbers. That's a bombshell. And that held to 28 days. A month later, the mortality was 49% for the standard group and 33%. That's a 16% absolute reduction in mortality. That's unheard of. When we talk about things like Gusto and all of the ISIS trials, and we talk about the benefit of or the lack of benefit of things like Plavix and Lipitor and all these types of drugs, we're talking about minuscule absolute reductions in mortality. This is a bombshell. This is 16 lives potentially saved out of 100. It's a huge, huge, huge thing. So it was not a surprise that this got all the press that it did. But can you believe that to this day, now we're in 2008, this has not been reproduced in an experimental model? There has been no subsequent randomized control trial that has reproduced this. And this was just in one center with one group of nurses and a very highly motivated team. There have been, however, some practical real-life applications, sort of the before and after sort of models. And if you look at abstracts number 2 and abstracts number 4, those are both examples. One's at Barnes Jewish Hospital, and one is at Loma Linda, just down the freeway from us, both showing that when new protocols were implemented after this study, that they had reductions in mortality. But you know those are not nearly as powerful as randomized control trials because there's lots and lots of things that can change when you're doing this type of study. And just the mere fact that you're paying attention to a certain group of patients and you're trying to do a good job and you're talking about it and you're advertising for it can really bring improvement to their care. If I know that the boss is watching how we treat patients with some certain particular disease, I'm going to do a better job on those. So those aren't as powerful. Anyway, that's what abstracts number 2 and abstracts number 4 are. Now, abstracts number 3 is a little bit different, and it's not quite the way that Mike Heller outlined this when he wrote the chapter. Abstract number 3, I think, is also very interesting, and I actually would put a little star beside that, beside abstract number 3. It's not a bombshell paper, but I think it's incredibly important, and the reason why is because it gives us some very important information. You know about this SIRS business? SIRS? I'm one of these stubborn guys, where when the new terms come out, like when they told me that I couldn't write headache and I had to write acute cephalgia, I got pissed. When they changed the terminology from unstable angina to acute coronary syndrome, I was also pissed. I was like, come on, man, give me a break, until I finally got on board with that. I didn't have a bank card until last week. I'm very reluctant to take on new things. But when SIRS came out, I was once again at the end of the pack in terms of actually knowing what it meant. And again, I had to have residents say, well, he's got SIRS criteria. And I kind of would stand there and say, oh, yeah, he does? Like, you know, kind of, what are those? What are the SIRS criteria? Well, the SIRS criteria are a change in temperature, their body temperature, up or down, increase in heart rate, increase in respiratory rate, or an increase or decrease in the white count. And do you guys remember how much was made of this? You all heard about SIRS, and a lot was made of it. And the reason a lot was made of it was because there was a presumption that if we can identify these people with SIRS, that we can intervene early. Same sort of idea with the early goal-directed therapy. And I have a personal story about it. Manny Rivers was at our place, and he was giving a talk, and he's just an amazing guy, wonderful guy, so friendly and warm, and really excited about what he's doing. And he came into our ER kind of like a preacher. And he was walking from bed to bed, and he was saying, there's another one right there, and that one there too. They're gonna die. They got sepsis SIRS, and he was just really into it. And he was saying, you know, you gotta identify these patients early. He was like a preacher. And he was saying, you got to measure their lactates and go for it. And they got SIRS and get on top of them. And the reason I like this abstract 3 as sort of the cynical naysayer is that they took over 3,000 adults at several centers. It was coordinated at Harvard. And they classified them into the strict criteria of SIRS, sepsis, severe sepsis, and septic shock. These are any patient that got blood cultures in a whole bunch of emergency departments. And what they found is, don't believe the hype. The patients who actually died were the patients with septic shock. They had a mortality of about 28%. The patients with severe sepsis, the ones that you would have recognized yourself in triage anyway because they look like they're about to die, they have organ dysfunction, so they either had their SAT is down or their pressure is down, they've got renal failure immediately apparent when their first labs come back, that type of thing. They had a mortality of 9%. But the patients with SIRS had a mortality of about 1%. Much, much, much lower, showing that there was a huge cutoff. When they actually had severe sepsis, as we've known it up until now, they died with somewhat of a high frequency. But the simple SIRS patients didn't. So probably we don't have to be as paranoid that patients that are occultly going to die as all that. And by organ dysfunction, by the way, if they had 4 or more organs dysfunctioning, they had an over 50% mortality. If they had 0 organs dysfunctioning, which you would know after your initial labs came back, only 1% died. So that's sort of, I think, an important article to sort of keep us grounded, that things aren't as misunderstood as we thought they were. Now, abstract number 5 is really silly. Really silly. Look at that for a second. That article is one of those articles saying that if we could only do all the things that we were supposed to do, like the proper administration of steroids for sepsis, for example, which, as we're going to see in a minute, probably doesn't help anyone. If we would only do that, we would save, what's the number here? 167,819 lives a year. Okay? Because, there was all that focus in the Institute of Medicine on, how we're killing people by, making medical mistakes. They're saying that acts of omission and not just commission kill people. It's a silly paper because it doesn't take into consideration all the harm that those therapies do, and they certainly do harm. But anyway, abstract 6 is important. I would put a star beside abstract 6. And this is a helpful paper for y'all because we have this sneaking suspicion, we meaning some of the people at our shop, that PA catheters, that Swan-Ganz catheters, aren't really helpful and that they probably hurt people. It may be that every single study in their history has shown that makes us believe that. I'm not sure. It may be that there's not a single study demonstrating that they help anyone that makes us think that. I mean, those are possible reasons why we believe that. But you know that. You guys call your surgeons, especially if you're working with residents in a teaching environment, they're getting a Swan if they're going to the surgical ICU. That's just the way they roll, right? That's what they think the ICU is all about. And so the fact of the matter is that it doesn't matter which way you look at this data, they don't appear to help people. Why might they not help people? Well, because even if they do guide management, you all know that they cause a lot of problems. Pneumothoraces, pulmonary emboli, air emboli, I mean, all kinds of problems. Sepsis, right? They cause line sepsis. I think that I like to avoid quoting Billy Mallon, but I have to quote him on this one, which is that the PA catheter is a dinosaur looking for a tar pit. So that's important, isn't it? Because we are talking about bundles of sepsis treatments that involve using PA catheters. So this sort of brings us to the meat of the matter, which is that we've got this goal-directed therapy thing going on, all right, where we put people through this formula and they come out doing great, okay? But you all know what the problem with it is that it's very time-intensive. If you guys ever saw the setup they had at Henry Ford Hospital when they did this study, you would be like, give me a break. They had dedicated resident rotation for that room where they did the goal-directed therapy. They had a lot of resources. They had a dedicated nurse. They had their own frickin' ICU. Okay, down in the ER. We can't do that. And so the problem is that some of those things are very intensive, and we don't know which one of those things made them do better. Was it the fluids that they got, the increased fluids? Was it the antibiotics that they got? Was it the pressors that they got? Was it the measurement of the SVO2? Did having a catheter, was that a critical element of it? We don't know the answers to that question, and we can't afford this, frankly. And so What we're doing now, and I'm involved in this as a site investigator at our place, is a new study called Process, which is looking at whether or not we can do Manny Rivers light. Forget about the catheter. Forget about the machine that measures SVO2. Just give them lots of fluids according to the protocol and put them on pressors when appropriate. And let's see if we can do this for cheaper. All right? It's great. So we haven't enrolled our first patient yet, but when that study starts to get going, we may have an answer if we can get away without doing the expensive and time-consuming parts, and dangerous, frankly, parts of the protocol, because I think central lines are frequently dangerous. So that's exciting, and that's what you need to sort of keep your ear to the ground and listen for.
As far as the numbers go on that study, wasn't the only difference SVO2 oxygen saturation?
Okay, so
they looked in both arms,
right.
and they had really good detailed information.
Right.
And the only statistical difference between the standard therapy and the early goal was the percent oxygen saturation.
The difference between them going into it or at the end of therapy? Because there were many differences between the group after their therapy. For example, the people that got the goal-directed therapy had much more fluid. They received much more fluid. That was one of the bigger differences.
Okay.
So it wasn't just the fact that they had their...
numbers that they came up with, the CVP would seem to be the same in both groups.
Right. Okay, so I have it here. So yeah, so he's asking, what was really different in the groups? Was it not just the SVO2 that was different, and maybe that's the only thing that makes a difference? And I'm saying, no, that's not the case. They received, the most striking difference is the fluids. The most striking difference in the treatment, in the experimental group, was that they got way, way more fluids. And so that's why some people are saying, hey, just tank them up and forget about the rest of the stuff. And that's what we're going to do in Process. And we can go into more detail on that afterwards. Okay, now, the next section here is about steroids, okay? Now, it's kind of a bummer because just after the manual was published, the New England Journal came out with a paper that's probably more important than any of the ones in here. Abstract 9 is a meta-analysis that tells us something that we've kind of feel is more or less known for the time being, which is that large doses of steroids, high-dose steroids in sepsis, kill people. That's what Abstract 9 tells us. There are 5 studies in that meta-analysis. The other ones aren't that important there. Abstract 9 is pretty insignificant. Abstract 11, they're not really helpful articles. They're not of sufficient methodology, I don't think. However, the new study that just came out, and I'm going to just hold it up for you here, is this called Corticus. This is just hot off the press. So this just came out this year in January. And the Corticus study is the largest study that looks at giving steroids to people with sepsis. We pretty much had established that high-dose steroids, I mean, you don't give a person a gram of methylprednisolone if they're in sepsis, and we've kind of known that's bad for a while. But there's been a thinking out there, and I'm sure that you've all run up against this many times, that giving them physiologic doses of steroids is helpful for them. And there is some further thinking based on some earlier studies that there are 2 types of patients, those whose adrenals respond and those whose adrenals don't respond. And that by doing a Cotrocin stimulatory test, we can identify some patients that need to have cortisone to supplement them because they're not responders. That was all the thinking. In the Corticus trial, which was coordinated in Israel at Hadassah, multinational study, there were 499 patients enrolled, and the conclusion, let me just get you see if I have the numbers here. The conclusion is that there was no benefit to physiologic dose steroids. Number 1, overall, and number 2, even in patients who don't respond to the corticotropin, the so-called non-responders. So their overall summary is, hey, this doesn't work. High dose, low dose, doesn't work. There are some complaints about the study. There are some people who disagree. The director of our critical care units at LA County actually has some concerns about it and thinks that steroids aren't completely dead in sepsis. But I think that this is an important thing for you to know about. 2008, big study showing that steroids don't seem to be helpful in either group of patients. You should still, of course, use steroids. If a woman comes in with lupus and she's on 60 milligrams of prednisone a day and she's hypotensive, you got to give her steroids. I mean, you got to give steroids to people who you think are steroid dependent coming in, and we all know that to begin with. Don't worry about that. No one's saying not to do that. They're just saying that you don't necessarily need to introduce it on the patient who's doing okay, who the pressure is up. You don't need to add extra steroids to those patients. That's the latest. And we'll see if that changes. It's going to be hard to get another study that big, I think, without a lot of money. Now, the next group of papers, abstracts 12 through 15, are about are giving antibiotics. Now, this is kind of interesting. One of the reasons it's interesting, just if I can make a quick aside, is that in the Surviving Sepsis campaign that Eli Lilly, the American pharmaceutical company, did, their big push to get people treating sepsis properly. And the reason why they did that campaign, obviously, was because they had a product that was on the guideline, which is Zygris, which we'll talk about briefly. In that campaign, in the 2004 guidelines for surviving sepsis, they classified giving their drug Zygris with a higher grade of evidence than they did giving antibiotics to people with sepsis, saying, well, there's no good studies showing that antibiotics work in sepsis, right? Actually, they're correct. There are very few studies that show that antibiotics work in sepsis. We all sort of fall back on our germ theory of disease. We kind of have this understanding that's, you know, but we take it for granted. And they were right in saying that. But I mean, obviously what they did was kind of sneaky. But when you look at what studies actually prove that antibiotics work for sepsis, the evidence is indirect at best. Abstracts 13 and 14 I would just throw out and cross off. They're of no help. They're very poorly designed chart reviews, and they don't really answer the question. Abstract 12 and 15 give some indirect evidence. And if you want to know what kind of evidence we have, it's like this. In the Monarchs trial, Abstract 12, they were looking at something completely different. They were looking at tumor necrosis factor alpha, and they were studying that. But as a side note, they actually looked back to see if they looked back to see the initial antibiotics that they gave patients, and to see whether or not they matched the sensitivities when they finally cultured a bug. And they found that the mortality was 33% at 28 days in the 91% of the patients who got the right antibiotic, and in the 9% that didn't, the mortality was 10% higher. That's as good as it gets for evidence showing that antibiotics work in sepsis. Abstract 15 is the same thing. If they got antibiotics that later were shown to be effective against their organism that was cultured out, their mortality was 64% versus 39%. So those are the best evidence that we have. About as good as water? No, it's better than water. No. Was there a water arm in there? It's better than water.
Well, you said before fluids is the biggest.
Oh, okay, but the antibiotics you're talking about in the early goal-directed therapy paper, yeah, there's no real difference in the antibiotics in that paper, as I can remember, in terms of like causing a difference in the groups. Yes, I see what you're saying. Yes, fluids might be. It's possible that fluids might be more effective than antibiotics, but that would be a big jump to say that. Okay, the next question is very interesting. I would put a little star beside abstract number 16 as well. It's one of those Annals of Emergency Medicine does little evidence-based medicine reviews that are kind of neat. And this is a really neat one, and it really hit home with me. You know, how long have we been arguing about what is the best pressor to start in sepsis, right? And I thought I was a genius, because I would say, oh, you got to use norepinephrine because it's better than dopamine. And I would actually, you know, make residents change their management and that kind of stuff. Oh, you got to add norepinephrine. And the nurses were, you know, that's a pain in the ass for them. And so anyway, I was a genius. So it turns out that in these people's opinion, Jones et al., and I'm sure that there's some smart people on that paper, they had 8 studies of sepsis that they put into their review, and they found no difference between the different pressors in any of them. There's still controversy about it. There's still people arguing about it. But I just want you to know that when it comes to the most recent literature review in our premier journal, that the verdict was that there's no difference between pressors. But here's the interesting part, and it's kind of like that antibiotic thing that we were just talking about. There's no differences over placebo either. So, no, so it's just interesting. So the next time think about it for a second. Just back up for a second. Think about trauma. You know, like a few days ago, I was on shift, and we had some guy who was bleeding from his spleen. He was stabbed, and I was helping to push the gurney to the elevator with the trauma surgeons, and his pressure was 70. And I said, oh, his pressure's dropping, and the guy looked at me and said, well, who cares? I mean, does it really matter? And you guys know that there was an important study in Texas many years ago that showed that penetrating trauma to the torso may be better off leaving them hypotensive and just fixing them surgically. Well, it could be the case, I don't know, it could be the case that the same is true in sepsis. Maybe leaving them at a pressure of 70 and taking them up and getting their pressure up to 80 with the fluids and not giving them pressors is just as good as using dopamine to artificially raise their pressure to 110. Who knows? Who knows? So it's just something to throw out there. At least what these guys are saying is that they don't have definitive proof that that's the case. So just kind of food for thought. Okay, now let's get to the real nasty, evil stuff here. Zygris. Is that where we're at? Yeah? Abstract 17, I think? We skipped Abstract 7 because Abstract 7, put a star beside Abstract 7. See, I didn't star anything for the first day, and now I'm starring everything. Abstract 7 is a beauty. New England Journal editorial written by 3 critical care specialists about the Zygris story, okay, which I'm going to give you the highlights of right now. But you've got to read this, and you've got to get your friends to read it. And have the nurses read it, too, while you're at it, while they're eating their Eli Lilly-sponsored sandwiches, okay? All right. There was a study, abstract number 17, which I think you could put a star beside, the Prowess study. You know, can't be a good study unless it's got a catchy name, Prowess study, that they did to study activated protein C for its use in sepsis. Okay, it was double-blinded, placebo-controlled, and multi-centered. One of the kind of bummers is that when we're trying to criticize drug companies, it turns out that their studies that they have a hand in are usually better designed than the ones that we do. But that's an aside. The N was 1,690, and they enrolled people with severe sepsis, very severe sepsis. Their Apache scores, if you're into using those things, were higher than 25. And they were also patients, in addition to the severe sepsis with these bad Apache scores, that had no comorbidities, like AIDS or cancer. Because, you know, people like that don't usually get severe sepsis, do they? So you're already talking about a very peculiar arrangement of patients. I mean, the very patients that get really sick and die are the patients that they excluded. And so they've got some bizarre, I don't even know how they got as many patients in as quick a time as they did. So what they found is that the 28-day mortality was about 25% after 96 hours of this drug Zygris versus 31% on normal saline. That's a 6% absolute difference. Nothing like the early goal-directed therapy, and again, on a much more picky group of patients, a very small subset of patients. But nonetheless, they got a 6% absolute difference in mortality. They also noticed, however, that there was a lot more bleeding in the Zygris group. There was 3.5% incidence of severe bleeding, serious bleeding in the Zygris group, and only 2% in the other group. And because you know that activated protein C, in addition to its presumed anti-inflammatory actions, which is how it's supposed to work in sepsis, is also, of course, involved in the clotting cascade. And so it can make people bleed when you give them protein C. So this was interesting politically, because with this one single study, they were able to get the FDA, they pushed and pushed and pushed and got the FDA to approve this drug for the treatment of severe sepsis. And that's a little unusual, just one study like that, especially with the funny group of patients that they selected. So the FDA said, listen, we're going to approve this drug. However, we're going to insist that in addition to approving it, you have to do 2 more studies, and we're going to tell you what kind of studies are going to be. We want you to study this drug in a broader group of patients, and we want you to study it in kids, okay? And so that's what they did. But in the meantime, Eli Lilly launched the Surviving Sepsis campaign, which I bet every single person in this room has received literature about and been involved with at some point in time, has seen their efforts. And they published in their guidelines in 2004 such things like that protein C was an integral part of sepsis management, and the sales of Zygris went up and up and up and up and up. And they did something very, very questionable, which is that they got a PR firm to brainstorm with them. What's the best way that we can get doctors to use this drug? Because it's $7,000 or so a dose. And what they came up with was that they would start funding grants for ethicists to help doctors decide who will live and who will die. That's a tough decision for you to make. And so they promulgated this campaign that made it look like Zygris was the magic bullet that doctors held in their hands that they should only give when they decide the patient should live. I mean, just a crazy thing. And the sales of Zygris just kept skyrocketing. And within a month or so after this campaign got kicked off, the results of the second trial, the mandated FDA trial, started to come in. And they were not good. In fact, the study had to be stopped because after 2,600 patients, they were reaching the statistical significance point of Xigris killing people from bleeding. So they stopped the study early, not because it wasn't working, but because they were approaching the point where they would have to say, this drug is killing people. Very, very, very suspect stuff. And of course, they didn't put any of the information about that subsequent study into the surviving sepsis guidelines. They didn't modify anything. They didn't make any statements. They just kept pushing and pushing and pushing, tens and tens of millions of dollars of drug sales, ethics campaigns, doctors in the ICU at our hospital coming down and berating me for not using the drug and not knowing about it, that kind of thing, because they were really pushing the intensivist hard on this. And you can tell when drug companies are pushing people hard, our consultants, because we feel it. You know, when they're very, very, very into something, sometimes there's a reason for it. The Resolve trial that came out from Nadell and Lancet, March 2007, also showed a problem in kids. And in fact, in that study, they had a 4.6% incidence of CNS bleeding versus 2.1%. And guess what their conclusions were? They said, well, the drug is still okay if the kid's greater than 2 months old. In other words, they dredged the data and found a group that it didn't kill as many people or didn't cause as many brain bleeds, and they said, oh, it's still the standard of care in that group of patients. Ridiculous stuff. And Dr. Nadell is on their list of beneficiaries. So that's Xigris. So Xigris really is something that is really very much up in the air still in some people's minds, but in my mind, it's something that's dead. It really is a dangerous drug. Just to summarize, I'm not going to go through all the summary points because I think we've covered most of the things, and I want to let you get out of here. Yeah.
For the ER docs in the group, the surviving sepsis campaign and that article we just went over are in the 2008 LLSA articles you're supposed to know and get tested on. So the stuff we just went over is part of your basically board certification.
See, Diane would have to tell me that because I think I'm still at 2002 for those things. I'm actually not board certified. I just play one on TV. Anyway, so the worst part is when you're actually recording the tapes and you actually haven't taken the test yourself. The last thing I wanted to tell you, which I think Rick put in the syllabus. Did he put in his essay on this topic at the end of it? He did, yeah. In his essay, he talks about all these things, but there's some things in there that are already a little bit out of date. One other thing that I want to tell you that's sort of hot off the press is in the January edition of the New England Journal, the same one that Corticus came out in, there was an article on intensive insulin therapy for sepsis. This is another thing that we've been told, isn't it? That we have to keep these patients, they have to keep their sugar strictly controlled. And there's been some supportive data of that, but most of it has been from poorly designed studies. This latest study that's come from Germany had 537 patients, and I'll give you the reference. It's Brunhorst, B-R-U-N-H-O-R-S-T, and it's in the 2008 January 10th New England Journal. They did a study where they had to stop the study because the group that was getting intensive insulin control was having too many episodes of dangerous, life-threatening hypoglycemia. The average sugar in the control group was 151, which probably in the ER we think that's not bad, and in the intensive insulin control was 112. Excuse me, they stopped the study after 537 patients because the safety board made them because of the hypoglycemic episodes. However, when they analyzed the data, there was no benefit. The mortality was the same in both groups. The organ dysfunction in both groups was the same. So this is a big blow for the intensive insulin therapy, intensive control of sugar people. And I just wanted to make sure I got that in there before the wire. So I've probably gone over time. I haven't got a watch. Thank you very much.